Good afternoon. My name is Sharon, and I will be your conference operator today. At this time, I would like to welcome everyone to the Progress on the Institute of Medicine Recommendations More Evidence conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you'd like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Ms. Andrea Broussard, you may begin your conference.
Thank you, Sharon, and good afternoon and welcome. Thank you all for taking time to join us for today's webinar. Before we go too much further, I want to mention that we are recording today's webinar. So if you miss a section or would like to pass it on to a colleague, you can find the recording by going to www.campaignforaction.org/webinars. Also, we will be taking questions over the phone at the end of the webinar, but you can type questions throughout the webinar using the chat function. Be sure to send your question to everyone. And we will be sharing the PowerPoint slides and the additional resources with you with a follow-up email. Remember in February, Dr. Joanne Spetz led a very informative webinar, and she's going to update us today. So I'd like to introduce Joanne. Joanne Spetz is a professor at the Institute for Health Policy Studies at the University of California, San Francisco, and Associate Director for Research at the Health Force Center at UCSF. She is the Principal Investigator and Director of the UCSF Health Workforce Research Center on Long-Term Care. Dr. Spetz was a member of the Institute of Medicine Standing Committee on Credentialing, Research, and Nursing, and a consultant to the Institute of Medicine Committee on the Future of Nursing. And she prepared an updated review of the evidence, and we will be sharing that document with you in our follow-up email. In today's webinar, we've asked Dr. Spetz to highlight select new studies that provide evidence for the benefits of increased access to high-quality care, discuss questionable conclusions in studies that compare physician and APRN practices, and review how political spending influences licensing laws. Thank you, Dr. Spetz.
Thank you very much. I'm here to present the updated literature, as Ms. Broussard said. And, of course, the literature continues to reinforce what we have seen in the prior literature reviews that were done by the Institute of Medicine for the Future of Nursing report, as well as some literature review work that we did a few years ago. Again, the public continues to have better access to high-quality care when nurse practitioners and other APRNs have full practice authority. So we conducted a we looked at a variety of different papers that have been published over the past 2 years. And I'm going to briefly review those and not spend too much time on them because I think the discussion and conversation that we have is very important today. There was a systematic review published by my colleague, Ying Zhui, who's at University of Rochester. And she invited me to participate on that, but I have to give credit to the first 2 authors for the most part. They did a marvelous job in looking at all of the literature and identifying what studies had been published that were of very high quality that looked at the impact of changes in scope of practice on various kinds of outcomes. And what we found in that was that states with full practice authority have seen an increase in nurse practitioners, especially serving rural and vulnerable populations. So the research very clearly linked the scope of practice to the supply of providers available. Other research by Hillary Barnes and colleagues found that nurse practitioner participation in primary care is greatest in the states that allow full practice authority and pay for 100% of the Medicaid rate. So these 2 factors are both important. The reimbursement matters and certainly incentivizes providers to participate in Medicaid programs, and also having full practice authority facilitates NP participation in serving the needs of those who are enrolled by Medicaid and other programs. A recent paper by Yao and colleagues found that nurse practitioners make more house calls to Medicare patients. This was using data in 2013, and they found that the nurse practitioners were particularly involved and specifically more involved than other providers, including internists, family physicians, geriatricians, general practitioners, and physician assistants. And while one might think that house calls to Medicare patients is a relatively small and perhaps unimportant component of care, there's a growing body of research of the importance of making care more available to people in their homes, especially if they have disabilities that may make it difficult for them to go to a doctor's office or clinic. Kurtzman and Barno and Kurtzman and some other papers, as well as Yang and colleagues, looked at the National Ambulatory Medical Care Survey data, which relatively recently included more data on nurse practitioner care. They found that, that nurse practitioner and physician-provided mental health visits in community health centers were more often happening with nurse practitioners, and the data indicated that nurse practitioner care was very comparable to physician care in most ways. This research, I'll give a shout out to Ellen Kurtzman. This was part of her dissertation work, and she has a very long history in studying quality of care issues. She had previously had a leading role at the National Quality Forum. These same authors also found that the NAMSES data suggested that the quality of nurse practitioner care did not vary significantly among states, regardless of laws regulating nurse practitioners. One of the arguments that's often made for restricting nurse practitioner work is that these laws are intended to protect patient safety. And the data that they analyzed found that there was no indication of quality differences between states that had the more restrictions versus states that were unrestrictive. They also found that nurse practitioners were providing more education and counseling services in states with full practice authority, and in states with full practice authority, NPs were more likely to be providing mental health visits and more likely to be prescribing psychotropic medications. In other words, having full practice authority not only was facilitating care in general, it was facilitating specifically important mental health services for populations that may often not have good access to mental health. We do know that there's been a national shortage of behavioral health providers, and nurse practitioners play a very important role in this work. These various studies conclude really that modernizing licensure laws is associated with improved population mental health. So using data from 1990 through 2014, a very long period of time, Alexander and Schnell looked at nurse practitioner prescriptive authority and mental health outcomes. And they found that modernizing state laws was associated with improvements in self-reported mental health, as well as decreases in mental health-related mortality, including suicides. So not only is providing nurse practitioners with full practice authority shown to be beneficial at the individual patient level, such as in the NAMSES data, but also more broadly for a community's population. The research in the past couple of years has also shown that care is more affordable when APRNs have full practice authority. There are a few different studies that have looked at this from different angles. Cost data are very hard to obtain, so I think all of the authors of these papers would recognize that there are various limitations in their analyses, but they use very large databases. Perloff and colleagues looked at Medicare claims, which is an incredibly large database, and they found that evaluation and management costs were 29% lower for NPs. Kleiner and colleagues looked at data and found that there was a 3 to 16% higher cost for well-child visits when there were restrictions on nurse practitioner practice in states, and found no evidence of differences in quality. So again, these restrictions on NP practice do not appear to protect consumers or improve quality. Finally, McMichael and colleagues looked at malpractice payments by physicians, and they found that when states removed their scope of practice restrictions, there was up to a 31% decrease in malpractice payments by physicians. This is likely because that once a physician no longer has a legal responsibility for supervision of a nurse practitioner, that reduces their individual malpractice liability. And again, there's no evidence that offering those restrictions improves the quality of care for the population overall. There have been a few studies that suggest that nurse practitioners order more diagnostic tests than physicians. And these studies are frequently cited and quoted as reasons that nurse practitioners need to have physician oversight in their practice. So I want to talk about these studies a little bit. One study was by Hamani and colleagues, and that was from 1999. And then another more recent paper was from Hughes and colleagues from 2015. So to talk about the Hamani paper, that paper was from some Veterans Affairs primary care clinics in Maryland. And again, this was from the 1990s, so this paper is quite old now. They reported that there were higher utilization rates of various measures of testing among nurse practitioners. But it's really important to note that there were 450 new patients that were assigned in this study, and overall there were only 9 nurse practitioners, 35 residents, and 10 attendings. So making comparisons between nurse practitioners and residents and attendings is a bit problematic. These are relatively small numbers, and in the data, the test could have actually been ordered by any provider, not just the primary care provider of record. So these shortcomings, I think, give us reason to take this study with a grain of salt when looking at it in the body of other research. Now, the more recent study by Hughes and colleagues was a much more expansive study. They were using Medicare claims, which, as I mentioned, is a very large data set. They were using a sample of 5% of Medicare claims. It had over 600,000 episodes of care in the data set. And in the data, they merged together the data for nurse practitioners and physician assistants. About 8% of the episodes of care were identified as being done by nurse practitioners or PAs combined. They reported that these providers, that they called advanced practice clinicians, were associated with more imaging services than primary care providers. Now, first, the differential was quite small. The difference was less than 0.5%. But the other factor that I think was much more important is that they grouped together NPs and PAs. And we know that about 2/3 of physician assistants work in specialty practices, and specifically many of them work in orthopedic-type practices and other practices where ordering tests and doing imaging would be normally part of their work. I was attending a conference where one of the earlier versions of this paper was presented. I think the paper had been accepted at that time. And somebody in the audience asked one of the authors if they had done analyses separating NPs and PAs. And they indicated at that time that this effect was primarily a physician assistant effect, but the paper was already accepted with the populations of providers pooled together. They also had done some sub-analyses of patients with low back pain and acute respiratory tract infection and found no difference in these groups for low back pain, and for acute respiratory tract infection, they found no difference in testing between the advanced practice clinicians and the physicians. So I think, these papers are going down a very important path in understanding the diagnostic processes that all providers are going through when taking care of their patients, but I think these papers have limitations that affect our ability to believe that NPs are not as capable of making diagnoses without excessive testing. A more recent paper that's been published by Liu and colleagues looked at Kaiser's primary care clinics in Georgia. Prior to 2008, nurse practitioners and physician assistants were paired with physicians to manage a patient panel, and then in early 2008, they adopted physician-only primary care. And they did comparisons between 2006 and 2010, so basically prior when they had paired panels, and then later when they had physician-only panels to see what happened. And they found between that change in the structure of their primary care that there was an increase in specialist referrals, there was an increase in hospital and emergency care utilization, and there was an increase in advanced diagnostic imaging. Now, again, this is a study only in Georgia and in the Kaiser system, which is a unique system in many respects. But I think that when you look at these various studies about testing it together, I think they're very inconclusive at this point, and there's not really strong evidence to say that NPs or PAs are doing something particularly different with respect to testing. For a closer look at the studies and the questions that I have raised about the methodology and findings, there's a document that you'll be able to download from the Campaign for Action website that you should take a look at that goes through these various papers. Now, there's been some more recent work by McMichael that looked at political spending. And this was a very unique analysis. Nobody had really studied this explicitly before. But he found that higher spending by physician interest groups was associated with a higher probability that a state maintains its licensing laws restricting NP and PA practice, and that higher spending by hospital interest groups increases the probability that the state would allow NPs and PAs to practice with more autonomy. So, a lot of people will argue or have debated to what extent are scope of practice regulations truly in place to protect consumers. The evidence does not support that these laws protect consumers or patients, and there is some evidence that really these laws are more the result of lobbying and political spending than they are rational policy decision-making. We hope that all of our representatives will really look at the evidence and the data in the future as they think about modernizing their scope of practice regulations. So I'd like to hand this over now to Winifred Quinn at the Center to Champion Nursing in America.
Great. Thank you so much, Dr. Joanne Spetz. And we really appreciate your participation on this and all the work you do with Andrea, and we just love working with you, so thank you. So there are decades of research, as we say here, to demonstrate that advanced practice registered nurses provide high-quality care to patients and are very supportive of family caregivers as a result. So, so we are very strategy-oriented, and part of strategy is to use different tactics, and one tactic is to use data. And Joanne has done a great job in updating us on what the new data are that are out there, and also like how some detractors are still using very outdated and erroneous data to substantiate their positions. So we wanted to let you know that we have seen some good examples of data. I mean, we always see good examples of data, and we thought that we would share with you a few that have been used recently, and in legislative wins over the last 2.5 years. So Nebraska and South Dakota, which have fully implemented, recognized advanced practice registered nurses skills, and West Virginia, which almost nearly did, all were very effective at using data to support their efforts. Recently, our Pennsylvania colleagues, Hillary Barnes, Linda Aiken, and Antonia Villarruel, prepared a very good 2-page brief with evidence bullets, and it's about the quality and safety of nurse practitioner care, the case for full practice authority in Pennsylvania. So you could do a search on that, and we'll have that link.
We'll post that.
Okay, we'll post the link so you could see it. You could access it there. And, you know, we also see, quote-unquote, evidence presented by the opposition in many states, most recently in Texas, and where they used the Hamani article that Joanne described. So it's outdated information, and it mixes up APRNs with RNs in another country. No, not in another country. That's another. That's another report that Andrea likes to tell me about. So, so you know, it's important to be familiar with the evidence, especially the evidence that you want to use for modernizing scope of practice laws. And it's important to be aware of what is the quote-unquote evidence that your opposition is trying to use, and be prepared to have talking points regarding those as well. And again, showing data and evidence is just one tactic in your overall strategy that we hope you have. And for those of you out there in the states that are in the throes of this and you feel like you could use some help on strategy, please let Andrea and me know. We would be happy to help you do that. And again, to reiterate, there are decades of research that demonstrate that advanced practice registered nurses provide very high quality care, and And of course, at AARP, our focus is on the people who need that care and the family caregivers who are supported by the efforts that advanced practice registered nurses provide to their loved ones and to the family caregivers themselves when it comes to advice and support. So with that, I'm very happy to hand it over to Andrea Broussard.
Thank you so much, Winifred. And we've gotten a lot of questions in the chat box. Yes, we're going to send you a package. We're going to send you the PowerPoint. We're going to send you the references that Joanne compiled when she updated it. We're going to send you a reference list from this webinar, and I'm going to send you the link to the Pennsylvania document that Winifred mentioned. So now we'd like to hear from you, and we have a lot of folks on the webinar, including some of the authors of these papers. So we're going to ask Sharon to open the phone lines. Press *1 on your telephone keypad to ask a question, and tell the operator your name. And you also could type questions in the chat box. So we'll pause a minute to get the questions in the queue.
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Once again, that's star, then the number 1 on your telephone keypad to ask a question. We do not have any questions over the phone at this time. Oh, pardon me, we do have a question from Nancy Lawton. Your line is open.
Hi, thanks. Can you hear me okay?
Yes, thank you.
Great. So I guess my question at this point is specific to Kaiser Permanente. I'm here in Washington State, and we're having a terrible time trying to get ARNPs, as we're known in Washington, empaneled in the Kaiser system. Is that happening in other parts of the country?
Mm-hmm.
Yes, this is Joanne. My understanding is that Kaiser makes decisions about this region by region, and at the local medical directors have a fair amount of discretion over that decision. The National Program Office, headquartered in Oakland, supports the utilization of nurse practitioners and has encouraged their utilization, as well as other APRNs. But it does vary region by region. So I think in some regions there has been more utilization of NP, PAs, midwives, et cetera, and in other regions there's less. It's very localized. But what you're raising is a very important point, in that in many states you can have a full practice authority situation, but individual providers, hospitals, medical groups, other kinds of care settings may place restrictions above and beyond what the law allows. And so the fight isn't over ensuring access to care when you get your scope of practice modernized. There still are organizations that are going to have to be educated about the value to them and their populations by making that expansion individually.
Thank you.
So Lisa Summers, my colleague, asked about speaking to evidence and advocating for all 4 APRN roles. It just turns out that most of the updated references are NP only, sorry, and some are, as you said, Joanne, NP/PA. On the February webinar on our website, there were many more articles about the other roles, and Joanne shared with me a publication on CNMs that's in press that's going to be striking evidence.
Yes, and I'll add, I've seen a paper presented on CRNAs. It was presented in the International Health Economics Association by a researcher at USC. That paper's in review right now for a very high-level peer-reviewed journal, and finds, again, that CRNA practice is highly safe for patients. It's an excellent paper.
And I'm just back from the NACNS Washington, D.C. Education and Practice Summit, and the CNSs are doing a good job on outcomes and getting their data published. One of our participants asked because the opposition varies so much from anesthesia to primary care, should we divide and conquer? And we have a couple schools of thought on that. Some states have done well, including all roles. Some states have done legislation just for one role. The most recent win, South Dakota, was the nurse practitioners and the CNMs, and that was a huge win. They were able to get both of those professions out from under the Board of Medicine. Then we have a question from Matt Keller, new to ANA. One of the arguments against full practice authority is that APRN malpractice rates are rising, which is borne out by data bank research I could find dating back to 2006 to 2010. Is this explainable by the concomitant increase in APRNs overall? Joanne, what's your thought on that?
That's an excellent question. I recently saw a paper that is either in review somewhere or has been published, in which the authors looked at malpractice claim rates, and NPs, I think they were comparing primarily NPs, PAs, and physicians, and NPs were much less likely to have claims against them than were physicians. So the rates might be rising, but the rates overall are still lower than physicians on average. And you'd have to compare the data to how much physician malpractice rates are rising to really interpret the data.
And then Edna is asking that CMS requires a physician to be listed on the chart in hospitals. How is this being dealt with? I would bring that back to the group. There are Medicare regulations in hospitals that there has to be a physician of record, and I have not seen Edna. Frankly, I have not seen much going on federally these days.
Can't pay attention to this right now.
Operator, are there other questions?
Once again, if you'd like to ask a question, please press star, then the number 1 on your telephone keypad. And we do not have any questions over the phone at this time.
There's one question that that I saw in the set from Sandra Cotton regarding the opioid crisis. And this is an important topic, of course. At present time, there are some states that continue to restrict nurse practitioner and PAs prescribing as well of certain scheduled medications. All states now allow NPs to prescribe Schedule 3 and 4. Florida used to restrict that, but changed it last year. One piece that I think is really important for folks to recognize, and this can be part of advocacy and lobbying, is that the opioid bill last fall allowed nurse practitioners and PAs to prescribe buprenorphine for medication-assisted treatment of opioid use disorder. That medication is really important because it can be prescribed by a doctor or NP or PA now. It was originally only doctors. But it can be prescribed in a basic office practice. It does not require that the person seeking treatment has to go to a methadone clinic or a facility. The guidelines and recommendations, of course, do involve the individual receiving treatment to seek counseling and the other therapeutic supports that are required to be successful in overcoming opioid addiction. But, you know, some states that have restrictions for nurse practitioner practice and physician oversight requirements, I am concerned that some of those states may not experience as much of a growth in provider supply for medication-assisted treatment if physicians do not support their nurse practitioners that they work with being involved in this type of care. So there's a huge opportunity for NPs to be more actively involved in opioid treatment, and these state scope of practice restrictions may be a barrier to them being able to do so. This is particularly pertinent in rural areas where the opioid epidemic is very deep. There's a huge lack of providers. There was some work at University of Washington that documented how many counties in the U.S. do not have a single buprenorphine prescriber. And so allowing NPs the practice that they need and the regulatory authority that they need so that they can fully take advantage of this opportunity to serve their patients is incredibly important. And I would argue from a lobbying standpoint, more important than concerns about overprescribing, especially if you have, you know, a state medication database, as many states do for managing opioid prescribing.
Yes, I think with the prescription drug monitoring databases, what we found is that the APRNs are very good at checking, and that's kind of been used against us, that we always check before we prescribe. But
yeah,
it's an issue. It's top of mind issue.
top of money.
And again, please press star 1 on your telephone keypad to ask a question.
Okay, we have a question from Veronica Dutchell. Your line is open.
Okay, thank you. This has been such an interesting discussion, the papers that you presented. I guess I'm wondering what should really be our focus in terms of a research agenda at this point. I know we're a pretty studied group. Can you talk a little bit about that? Does the question make sense?
Oh yes, thank you, Veronica. I think what Joanne said on the February webinar is that we need more research from the other APRN roles. In addition to NPs. And Joanne, your additional thoughts?
Yeah, I think the research across all the APRN roles are very important. There is that new paper on midwifery that's come out, and I think that there is a growing, I think there are going to be other papers on midwifery, and as I mentioned there, I know that there's a paper on CRNAs coming out. One of the largest gaps we have is around research on clinical nurse specialists, and their scope of practice varies widely across states. In some states, they're not even really recognized independently. But we know that they play very important roles in a variety of settings, including mental health. So I do hope at some point we get a broader body of research regarding their practice and their contributions to providing healthcare services and meeting the needs of our population.
Okay. And I would say from a policy point of view, it was very unfortunate that with the federal restriction allowing NPs and PAs to sign prescribe buprenorphine was not extended to clinical nurse specialists, because we know psychiatric clinical nurse specialists are on the forefront. But I would also say we need NPs to sign up to do this, because it was the legislation is time restricted. I forget how many years it was. So we really need NPs to sign up to be these providers, to show our input, input. Other questions?
We have a question from Lisa Summers. Your line is open.
Hi, thank you. Andrea, you've heard me say this before, but I just wanted to pipe up and sort of make a comment, but also ask a question, really, in terms of when is enough is enough. You know, the midwifery effectiveness literature that I studied in the early 80s started in 1925 with, you know, Mary Breckenridge and the Metropolitan Life Insurance data. And my comment is, I just think it's really important for us not to fall in this trap with regard to quality and effectiveness of always feeling a need that we have to have another study and a newer study, and, well, that's 5 years old. We are the only professional group that gets studied like this in terms of our quality and effectiveness. People don't ask, when was the last time you saw a study on the quality and effectiveness of dentists? So I think at some point, and I thought the IOM report was that point, we need to shift the conversation to say, wow, you know, midwives get really great results. And the question is, how do they do that? What's the mechanism of providing care that results in those good outcomes and not get caught in the trap of always having to have another newer study about quality and effectiveness. Been there, done that, enough is enough, my opinion.
So thank you, Lisa. And is there a question, or is that the rhetorical question?
Well, I guess I was sort of looking for a response to that, but
okay,
the question is, when do we call enough?
Yeah. So very good question, and actually, I am hearing more and more questions from legislators about several things, several factors regarding quality and also cost that legislators are asking, especially as more and more states are modernizing their scope of practice laws, and to see what is there a difference. So this is what legislators are asking for, and we really don't have those data. So I think they would be data that would be interesting to unearth, and that would be just one of several items in the advocacy and coalitions toolkit to approach them with. And frankly, I also believe that one of the most powerful pieces of data, if not the most powerful piece of data, is personal story. And I have yet to see a state provide the perspective of a patient or a family caregiver, except maybe with one or two exceptions. And so if the coalitions out there that are working on this could help find a story of how outdated scope of practice laws have been a barrier to a person's care, and have that told by the perspective of the patient and not the nurse, that would be ideal.
I'd also like to point out and give a hat tip to the American College of Obstetricians and Gynecologists. They issued a joint statement, I think it was about 2 or 3 years ago, with ACNM regarding their joint interest in ensuring adequate maternity care for women in the United States. And they really made a pretty strong statement, and I've seen leadership of ACOG speak about this, that they recognize that CNMs and certified midwives have a particularly important role in meeting the needs of women who have relatively normal pregnancies and births, which is their expertise, and a recognition that obstetricians and gynecologists should be focusing their extensive educational background on the complicated cases and the surgical deliveries, as well as the broader gynecological surgeries. Now, not every state obstetrician and gynecologist organization goes along with the degree to which the national organization has said we believe that CNMs provide great care and need to be supported in their practice in every way. But there is an opportunity there, I believe, from an advocacy standpoint for nurse midwives to leverage that national support and that joint statement as part of their advocacy. Unfortunately, we don't have any similar such document for anesthesiology or for nurse practitioners.
Mm-hmm. Yeah. Operator, are there any more questions?
Yep. Your next question comes from Nancy Barr. Your line is open.
Thank you very much. Just a couple of comments and a question. What is the Governors Association issuing any statements on, advanced practice nursing in terms of its importance? And I know that some of the state governors, especially in Kentucky, have said, forget all this nonsense. We're recognizing these advanced practice nurses at all levels because of their ability to provide care, and I'm assuming in their rural areas. So I'm just curious about what that might be. Also want to say that the American Academy of Pediatrics has indicated that school nurses, doesn't say advanced practice nurses, but it says school nurses should be mandated. in every school, because that's where healthcare begins. So I think we need to applaud them for advancing our practice at the school nurse level, and I think that's really, really important. And then the last comment is, I too believe, as Lisa Summers said, when is enough enough? And I just needed to make that comment. Thank you.
Thank you all, and we're getting some private messages too that enough is enough. What we're seeking are, when states modernize their laws, what has been the effect. And we have some anecdotal stories of APRNs who open practices in rural and underserved areas, and that's helpful when we can share them with other states. But then we get states that say, well, that's not like our state. When you've worked with one state, you've worked with one state is our challenge in modernizing the laws.
Right. And I'm going to add to that, enough hasn't been enough yet. And this is what the state legislators, this is what the state policymakers are asking for. And in advocacy, it's the policymakers that hold the power, and if you want to influence that, you would want to satisfy their questions. And so we know what they're asking for, and it is a comparison, and how would it potentially impact their own state, and how would it help people in their own state. And so I think it would be really important to help satisfy those questions.
Mm-hmm. Yeah, I think it's important to really know what's the penetration of APRNs in your state when you're going into these when you're modernizing the laws. Are there other questions?
Your next question comes from Matthew Keller. Your line is open.
Hi, this is Matt. Thanks for all your time, everybody. I'm just wondering if you guys or anybody on the phone maybe or that's in chat is able to tell me if there's any online repository that kind of lists all this research, not just the new research, but the research going back to the IOM report and whatnot even. Is that all listed online anywhere?
Yeah. Joanne, can you help answer that? Are you on? Okay, there you go.
Yeah, sorry, I was on mute. Excellent question. I also am trying to scroll through some of the questions on the chat line as well. Let's see. So I'm sorry. I was reading one of the chat comments, so I need you to ask the question again. My apologies.
So Matt, I would say that the APRN work group has been has a large document on evidence. You should be talking to Ralph Cole from AANA. They've had a document and they continue to update it, and they do have links there. AANP on their website has resources. We have resources on our website too, the Campaign for Action. There are many published articles, and in some of the chats that I'm reading, there are articles that have limitations too. So you have to be careful on how you use them. But Joanne has compiled, if you go to our February webinar, Joanne compiled evidence from when the IOM report was published, and then she has just updated that, and we're sharing that document with you after this webinar. So we continue to update it. There's many journal articles.
And in terms of assessing quality of articles, there are some review papers out there, not very many. The one by Ying Zhui is one of the more recent systematic reviews of the literature related to nurse practitioners, and I think there are a few others that are a little bit older. So those articles are in the peer-reviewed literature, but I think some of these compilations that have been developed by AARP and the various professional organizations are more comprehensive, but you do need to be careful about which articles you cite, in the same way that I think people who try to argue that nurse practitioners order more tests need to be careful about citing a paper that's nearly 20 years old.
Yeah. Madeline, would you advance the slide one? I want to share with you on our website our campaign resources, because the Campaign for Action does have, when you go onto resources, if you go onto issues, I had Madeline, it's small for you to read, but the first issue is increasing access to care, and then on the far right is webinars. So that's where our webinars are posted, and the documents that we discussed on today's call will be here. But we have a load of resources. Someone referred to the National Governors Association. That's a seminal report, and that's on our resource. When we had our webinar about Nebraska, we posted resources, and we posted some updates from states that had modernized their law. We posted an update from Minnesota, we posted an update from Nevada, and I know the nurses and the boards of nursing in those states continue to collect and report that about the increase in APRNs in their states. So we're chock full of resources, and I'm hoping my colleagues from our communications department will notice after this webinar how many hits we get to our our resources slide. Are there other questions?
Your next question comes from Stephanie Burgess. Your line is open.
Hello, everyone. Can y'all hear me okay?
Yes. Hi, Stephanie.
Hey, first of all, thank you for all this wonderful information, and yes, thank you for all the resources that you have provided and continue to provide. I just wanted to comment about those stories from patients and other individuals who support our practice. We have done a little bit of that, but not a very good job in South Carolina. So what we're going to do next go-round is when the hearings are held, we're going to have other interested groups such as agencies who support us, as well as patients, rather than APRN speak, because hopefully that will convince the subcommittee and the committee to vote favorably on our legislation. But they've not listened to stories, or some of the stories, and they certainly have not listened to the data. We've given them tons of data, tons of facts, tons of information, but they've not paid attention to that. Their decision-making has been based on hearsay from physicians, or mostly the physician groups, and they use those very same arguments. You know, we need to be supervised because we don't have as much training or education. We tend to order tests, those kinds of things. So we're going to use that other tactic that you had suggested, so thank you.
So Stephanie, we over-order tests. That's why I asked Joanne to speak about the Himani article. And I remember emailing that to Joanne, and her reply was, "Are you kidding?"
But that's what they do. They come and they present that data, and then the legislators sit there and think, oh, okay, and this must be valid, and it must be current data, knowing perfectly well that it isn't. So thank you for sharing that, and when they bring that up again, I'll certainly be quick to respond to them. It's been difficult for us.
I'd be careful about saying that, you know, the data isn't necessarily valid, but I certainly would point out that it was a very small study done nearly 20 years ago, and the more recent research doesn't support that. Another advocacy strategy that I think could be important for some states is to look at some of the healthcare delivery systems and possibly insurance companies if they're operating accountable care organizations or engaged in other kinds of managed care contracting. You know, for retail clinics, nurse practitioners are a very important part of their delivery of care, and they provide a, fairly low-cost method for individuals to access care for urgent but not emergency needs, as it were. And the research is that in states with restrictions on scope of practice, that retail clinic costs are higher. So that hurts consumers. It also hurts businesses in the community. The other piece would be looking at, if you have an insurance company that is operating accountable care organizations that might be involved in house calls programs to prevent readmissions, for them, the additional costs that might be associated with having to hire physicians to supervise their NPs may be adding to their costs. And that, in the end, spills over into higher costs into the Medicaid program for the state. It can spill into higher costs for employers in the state, which could be Chamber of Commerce might be an ally for you. So these are folks, organizations that have not often been as vocal, but there may be an opportunity now to bring them on board, given that we do have this newer research on house calls delivery and on retail clinics.
And that's what we're going to use. So thank you. And we are reaching out to those groups as well as other groups who we think might be very supportive in terms of economic development, growing businesses, and those kinds of things. So thank you.
Thank you, Stephanie. And it reminded me, I'm also going to include on this very long, chock-full email that Madeline's going to be sending out, the Charting Nursing's Future issue. Because the Charting Nursing's Future is the first place that I have seen in one place the myths, and the cost of care. So we'll add that to the list that goes out to it. Madeline, can the folks read the chat boxes when they write it to everyone?
Yes, so if it's written to everybody, everyone can read it.
Yeah, I thank my colleagues for these great recommendations, and some resources.
Copy and paste the chat box.
Yeah, and Madeline will copy and paste the chat box, and I'll see in this follow-up email that's going to be very long other additional information to send. And I would remind you, my email is abroussard@aarp.org. And operator, are there any other questions before we close up?
Your next question comes from Karen Lyon. Your line is open.
Yeah, I just actually wanted to go back to a comment that was made earlier about state-specific studies, or that everything was single state, and that's so true. This last year, we didn't really try to move anything through in 2017 because it was a budget year, and we're limited in our legislative proposals that can be made. But when we did try it in 2016, we had data out our ears. I mean, we probably had 3 piles 3 feet tall of all of the national data. And of course, all we heard was, well, we want state-specific studies. So then we proposed having, doing a pilot study to eliminate collaborative practice agreements and actually look at outcomes, because we believe that there's no relationship whatsoever between a collaborative practice agreement and the outcomes that APRNs get. But they didn't want to do that either. And so one of the things, that I heard in Dallas when we met in May, those of us who come from conservative states, was getting to know our legislators and making those visits outside the legislative session, because legislators really don't know us personally like they know the medical society and the Board of Medical Examiners, because they get out there and do those things, and of course, as we know, they give money. But it's more about developing those relationships, and I just don't think we're doing a good job outside of sessions to really develop those relationships, and I really think that's something that we need to work on. And so I just offer that up. We'll continue. It's frustrating, to me as a nurse of 43 years to still be trying to move this forward and fight, but I guess I'll do it until I drop dead, because I am an APRN, a clinical nurse specialist, and I believe in this. It's my passion. It's my one little project that I'd really like to make a difference in before I hang it all up. But I just wanted to add that, those are some of the challenges that we have.
So, Karen, thank you so much for bringing that up. This is Winifred again. And the points you made about developing relationships and being donors. Those are also two other tactics in an overall strategy. And you're right, it would be good if the coalitions that you worked with were more directly engaged with the policymakers to help demonstrate that you are also not just an excellent source of information, but that you support the policymaker as well.
And Karen, this is Andrea. I would like to say that in every state that has had success, there's been a person like you working tirelessly, and I'm thinking of Minnesota and Mary Chesney. And what they did in Minnesota is they targeted legislators. They had individual reach out, and I think Pennsylvania is doing that type of work, and it's really, like Wynn says, it's relationships.
Right, and of course you would want people who are living in the legislators' districts to especially be those relationship owners, so to speak. Yeah,
and particularly NPs in practice in their districts. So we're getting to the top of the hour. Operator, are there any last calls in the queue?
And we have 3 more questions. We do have a question from Maureen Cahill. Your line is open.
Okay, Maureen.
Maureen, your line is open.
There, can you hear me?
Yes, go ahead, Maureen.
Oh, sorry. I was just trying to make a comment earlier, so it's not very pertinent now, but that you could find some of those older studies if somebody's trying to look at the early outcome studies, both on the NCSBN website articles section in the APRN part, but also in the Future of Nursing report. If you look at that part that has that spoke to the APRN issues, there were sites in there that were some of those early studies as well. And, of course, that study in nursing economics that went from the 90s through 2008.
Right.
That's
we'll
it.
Take the next question. Thanks, Maureen.
Your next question comes from Sharon Holder. Your line is open.
Sharon?
Sharon Holder, your line is open.
This is Karen Holder. Can you hear me?
Oh, yes, go ahead.
Oh, okay. Actually, mine was an earlier comment as well, but I've come up with a couple of things. So I'm Karen Holder, and I've been working in health policy in Arizona in a variety of ways. And I wanted to just put out some ideas for people, actually. One of them, I think that one of our strengths is patient advocacy, and so I think regardless of what your legislator dismisses or doesn't dismiss, it's good to have some patient stories in your pocket. For a lot of legislators, they work very well because legislators are people, and they typically in most states have other jobs, and so they want to know something that connects them to you. So I would really advocate for the patient stories. I want to thank you all for the updates on the data because I think that's equally important, if not more so. And I agree also with developing relationships with policymakers. And one of the ways that we've been able to do that in Arizona, and this is an idea that I wanted to throw out for people, is that we've created an Arizona Advanced Practice Nursing Coalition. It's all online, and we have meetings or webinars every quarter, I think it is. But we've learned so much more about the different roles, and it's been because we've gotten together under one umbrella instead of NPs doing their thing, CNS is doing their thing, CRNA is doing theirs, and CNM is doing theirs. So I would really put that out there as an idea for every state. It enhances your power. It enhances your knowledge about your colleagues, especially when they work in other specialties. And it also helps us all to come together and say there's a hole in CNS research data, for instance.
Mm-hmm. Thank you. That's helpful.
Thank you.
And our earlier participant, Veronica, is leading that coalition in Maryland, so a shout out to her. We'll take our next to the last question.
Okay. Your next question comes from Patrice Little. Your line is open.
Yes. Thank you for this webinar today. I'm very new, like I'm a novice to all the health policy, and I just wanted to know your thoughts on like a 5-year fellowship for new APRN with a collaborative prior to their independence, and if there's any studies to support this, because I've heard it mentioned and wanted to know if it would be a good start for states where there's great opposition from the medical association.
So,
sorry,
Patrice,
that's like 3 questions.
Yeah, I'm going to answer one of them. So the American Nurses Association has a document under their advanced practice nurse section under their policy and advocacy where they talk about this transition to practice, and there is no evidence that a transition to practice period is needed, but we have found in states that this has been a political compromise. So if you don't find the document, just email me, abroussard@AARP, and I'll send it. And we'll take our last question.
Once again, if you'd like to ask a question, please press star 1 on your telephone keypad.
Oh, I thought we had another question in the queue.
Yeah, we do not have any more questions at this time.
Great. This was a fabulous webinar. We thank you all. Madeline's going to be very busy assembling stuff to send to you. Feel free to email me, abroussard@AARP. Have a great summer, and we'll talk to you in the fall.